Yes, can hear you
Oh,
perfectly.
great, great. Good to be with you today,
So,
Lucy. How are you?
I'm well, Dr. Zoutman. Um, do you do you want me to call you Dick or do you want me to call you Dr. Zoutman? I'm good either
Oh,
way.
Dick is fine. Yeah, that's just fine.
Okay. Dick, we've had quite a bit of drama in the community lately, and so there are multiple spaces going on to try to deal with all of that,
Okay,
which I don't think they will make much progress personally, but we'll just carry on
absolutely.
if that's
That's
okay.
fine. No, that's
Okay,
great.
cool.
Yeah.
Very good. So yeah, so Jelly, sorry to have cut you off. What were you saying?
Oh, I was just going to echo your sentiments that you just talked about because I'm a frequent visitor to these chat rooms, and this weekend the animosity and disagreement and all kinds of stuff going on that I had to like avoid them the last couple days. So, anyways, yours is a kind space, and I look forward to hearing from Dr. Zelman.
Exactly. You know what? I'm happy. I'm extra happy to have you in the space today, yeah, Dick, just because I feel that it puts us on track again in terms of what our real goals are in the community, which are to get facts to help us fight this virus that we are I call it the many-headed
Yeah.
hydra myself. But Joe, if it's okay with you, I'm going to drop you down to listener. Is that
I'm
okay?
cool with that. I'm just working
Okay.
on my model right now.
Okay. Okay. Well, we might as well start the space. Um, I'd like to welcome all of you to the space this afternoon. I realized that with my last space with Dr. Herger, I was very diligent about introducing everyone except for myself. So I'm going to introduce myself. My name is Lucy, and I'm a member of the COVID conscious community here on X or Twitter. I consider myself a COVID shielder and a long COVID ally. I'm a retired social worker with 30 years of experience in working in the fields of addiction and child protection. I live with my 24-year-old son, who's mildly autistic, and I also identify with the neurodivergent community. Um, I'm also wanting to introduce my co host, David Upp, who is a volunteer with an agency based in Vermont called All Brains Belong. It's an organization that focuses on promoting neuro inclusion, both in healthcare and in the community. Dave himself has some chronic health issues and has a particular interest in the impact of COVID on the neurodivergent community. David is a talented co host who I find often reads my mind and is really good at putting relevant material in the nest and in the chat bubble. So, the nest, for those who don't know it, is the area above the chat, and the bubble is the one to the bottom right of your phone, um, in case, and we post relevant information there. Our guest today is Dr. Dick Zoutman, MD, FRCPC, CCPE, and Clinical Director. Dr. Dick Zoutman is Emeritus Professor in the Faculty of Health Sciences, School of Medicine at Queen's University. Actually, Dick, you're retired from that position, are you?
No, I'm still teaching. I've retired
Okay.
from clinical practice, but I'm still teaching and faculty at Queens.
Okay, thanks. Dr. Zoutman is the past inaugural Chief of Staff at the Scarborough Health Network in Toronto and past Chief of Staff at Quinte Health Care in Southeastern Ontario. He is a fellow of the Royal College of Physicians of Canada, specializing in internal medicine, infectious diseases, and medical microbiology. He is also the past professor and chair of infectious diseases and of medical microbiology at the Kingston Health Sciences Center and Queen's University. Um, During the 2003 pandemic of SARS-1, Dr. Zoutman chaired the Ontario SARS Scientific Advisory Committee, which was responsible for advising the Ontario government on the management of the pandemic. More recently, Dr. Zoutman is a member of the editorial group of the John Snow Project, which most of us are familiar with in the community. They're a nonprofit organization aimed at informing the public about the ongoing danger of SARS-CoV-2. A more complete biography should be available in the Nest. I think Dave posted it up there. Dick, is there anything that I've left out that you would like to add?
No, that's great. Thank you. Thank you very much for that lovely introduction.
So, yeah, I'm really happy to have you here today. As we know, we are just kind of exiting the peak of a wave of COVID infections that have come over the holiday season and had been forecast to kind of dip a bit around this time. But there's always more information that we need to know. And we know enough to know that if we are in a bit of a dip, that we cannot let down our guard and that we need all the information we get in order to know how to protect ourselves, our family, our families, and children who are seem to be vectors of infection and are in schools with very little mitigation. So yeah. So is there anything that you want to say off the bat, Dick, or shall we just start off with the questions?
Yeah, well, thank you very much, Lucy, for inviting me, and welcome everyone. It's great to meet you all in this space, and I hope to be able to have more conversations with you. I just want to start off by saying, nothing that I'm going to talk about should be considered personal medical advice. Obviously, for your own health needs, you want to consult with your own physician or healthcare practitioner. I'm retired from clinical practice, although I still professor at Queen's. And so our purpose here is to discuss the scientific evidence and questions, and I'll do my best to answer the questions that Lucy has prepared for me, and I hope to have an engaging conversation with you.
Thanks, Dick. I Something that we didn't go over is I'm not quite sure how much time you have in your busy schedule to allot to us, because that will dictate kind of the format of the interview. So can you give me an idea of how much time you have?
Oh, yeah, not really a problem right now. I don't have anything booked until quite a bit later, like 7 o'clock my time. So we've got an hour and a half anyway. If you want to use it all, it's
Okay.
really an hour and a half. Yeah, it's fine.
That's great. Thanks, Dick. So I'm going to say to the people listening that there may be time for questions at the end. And what I'd request that you do is that if you have a question, that you DM it to David It Up, and he will screen the questions. And if we have time to get to them, we will call you up to speak. So thanks. So Dick, can you explain to those of us to those who don't know you, what was your role during the original SARS pandemic in 2003?
Right, Lucy. Well, that takes me back, takes us all back, doesn't it? Back to 2003, now 20 plus years ago. And I remember it like it was yesterday because it was life changing in so many ways for so many of us. The first time a coronavirus that had behaved in this way and caused a pandemic of SARS-1. When it hit Ontario, like many jurisdictions, we were not well prepared. And in the mayhem that occurred in Toronto, especially where it hit hard, I was asked to chair the Ontario SARS Scientific Advisory Committee, which is like the science table that we've had in Ontario and many other similar entities across the country in different jurisdictions. That group was inside government. We were not, as the science table was this time, was outside of government, situated in the Dalalana School of Public Health in the University of Toronto. This was inside government because it's just the way it turned out. That wasn't by plan. It's just the way it turned out. And actually, you know what? In hindsight, it actually worked quite well. So I chaired that enterprise. We were a committee to give advice to the Ontario government and to help write plans for how we would manage this. And at the time, these came out as what were known as directives. These were directives from the minister and from the Ministry of Health to the healthcare system to do certain things. That was one of the key things that we did, which in hindsight now, because I've had a lot of time to think about it, was a gutsy thing, and it was a decisive thing. But we recommended going to a system-wide code orange, which was closing down the healthcare system as far as you could. Obviously, emergencies and labors and deliveries and emergency surgeries and those sorts of things, emergency departments had to operate. But since we saw SARS-1 spreading in hospitals, mostly in healthcare settings and hospitals and ambulances and whatnot, we took that approach and it worked. It was very challenging, but it was helpful. Anyway, there's lots more I can talk about that. I'm happy to reminisce about that. I was then asked to sit on the expert panel on SARS and infectious disease control, which was in the aftermath, a provincial committee that was established by the minister, Minister Smitherman at the time, to come up with recommendations on how we can deal with SARS and improve the public healthcare system. We came up with a large number of recommendations, as these kinds of panels tend to do. And the Ministry of Health under Dalton McGuinty at the time, the Liberal government, and the Minister of Health, George Smitherman, took all of that to heart and committed and really did enact almost all of it, what was known as Operation Health Protection. And as a result of that, I became the founding co-chair of the Provincial Infectious Disease Advisory Committee, which still exists to this day, and I chaired it for some 8 years. That committee was directed to develop infection prevention and control policies and procedures for all of the healthcare system, including vaccinations, including surveillance for infectious diseases and interventions, and a whole variety of things. And we worked very, very hard to establish a great deal of documentation and really recommendations that were well documented for the province and for practitioners on the ground. And so this was a committee of practitioners who were in the real world, including from occupational health, and we did have engineers and all sorts of people involved. And it became quite a well-known brand around the province and around the country, and indeed around the world. The other activities I got involved with for those years was really quite a very busy time for me in being involved in trying to build a better infectious disease control system for Ontario. And I also sat on some technical committees with the World Health Organization. So there was an awful lot that went on, and we, what is known as Public Health Ontario was developed, and really things were looking good in Ontario. We kind of tested all of this in 2009 because we had a pandemic plan that was done for the province, which was multidisciplinary. It was comprehensive. And with the H1N1 pandemic in 2009 actually worked pretty well. Things it wasn't never smooth, and it's always hectic, but it worked quite well. Unfortunately, when COVID hit, the pandemic plan hadn't been touched since 2013, basically, 7 years, and so much of what was built didn't get put into place, and Public Health Ontario had difficulty, I think, finding its place, and it was frustrating to watch. I was no longer in those positions. I was chief of staff at Scarborough Health Network, and I watched it all unfold, and it was disheartening, to say the least.
Yeah.
Hi, Lucy, you still there?
We hear. Can you hear me?
Yeah, I can hear you good now. Yeah.
Okay. Yeah. No, I just had a phone call coming in. Yeah, I'm going to explain to the people who are listening that that occasional screeching in the background is your lovely pet parrot. So I
Oh,
forget you,
yes.
just so people know that that's not a glitch in Twitter. Dick, what was your parrot's name again? I forgot.
His name is Cosmo, and he does like
Cosmo.
to join in on conversations. I've closed the door to my office, so hopefully you won't hear him quite so directly.
Okay. So it sounds like the plan that you developed back in 2003 and was tested in 2009 was quite comprehensive. Um, I- and it begs the question of why, well, we'll get into it, but why was the SARS-1 virus able to be controlled so well, whereas that's not the case for SARS-2? Why have they been handled so differently?
Yeah, they have been handled differently. I mean, the viruses are similar. They're both coronaviruses, but they're also very different. Remember, SARS-1 had a much higher mortality rate, case fatality rate, around 15%. So it was very, very dangerous virus. But it wasn't as infectious as COVID, and it also didn't seem to mutate. We didn't have variants, largely because we got rid of it fairly quickly. Again, I attribute that to the intense efforts to shutting down the healthcare system, among other things. Um, SARS-1 was less contagious but more fatal. It was limited to the healthcare settings. And so that seemed to, by closing down the healthcare system as far as we could, that seemed to have the desired effect. We also didn't see asymptomatic spread of SARS-1 that we know of, and that was helpful. We now know that it was significantly airborne. We didn't know that at the time, and because we'll get more into airborne discussions later. So I think that we were able to control it because of it being less infectious. It didn't have the reproductive number. It didn't mutate, and it seemed to have a selective environment that I don't know if we understand why, but it really didn't spread particularly efficiently in the community, which was a good thing.
Okay. Yeah, you talk about the realization that SARS-2 was airborne, and that seemed to be kind of late in coming. I remember reading some earlier material that where you had discussed it, and the thought was back then that it was borne by droplets or passed by droplets. When did you realize that that SARS-2 was airborne, and how did that realization come about?
Yeah, everybody has their own journey on that. Remember, I worked in the area of infection control, for the last almost 40 years, and so I was taught and read in the books that I studied that these things were droplets, and the definition for between droplet and aerosols was 5 micrometers, which we now know isn't true either. It's 100 micrometers. So I was sold a bill of goods. And then I taught that on to others, and I'm not happy about that. But it's what we knew. at the time and what we had to work with, the amount of research that has been undertaken really since COVID has been astronomical. You know, there's almost 700,000 published papers on COVID and SARS-CoV-2 since the onset of the pandemic. That is unprecedented. To have that kind of published publication record. That does not take into account preprints and a whole bunch of other things in media. So there's been an enormous amount of information and scientific discovery, and that's, if there's any good news, that is good news that happened. So for me, really, we started off in the chaos of the March break of 2020. In the hospital sector, we didn't have much PPE, and the stockpiles, as we now know, both federal and provincial, were never maintained. So when you made the call to say, please send me my truckload of PPE to my hospital, no one answered the call because there was no PPE to send you. So we had to use what we had, which were surgical masks that we had in abundance, and N95s were hard to come by. And because the provincial stockpile and the federal stockpiles were not maintained. For me, when I started to see the data towards the late 2020, and there was the WHO kind of flip-flopping, and then Public Health Agency of Canada quietly sneaks it in the latter part of the fall of 2020. You start thinking, we have to change our thinking. There was more evidence of airborne spread, and certainly the number of papers between late 2020 and early to mid 2021, I count at least 45 papers that came out in rapid succession. And these looked at what was going on with the transmission. And so I started rooting around my house and my office for N95s, in around December 2020, November, December 2020. I had a few, and I would double up with the surgical masks of whatever I could work with. And I wasn't able to get an order filled until the new year of 2021. And then I've always worn N95s at a personal level. We learned that viable pathogens, such as the virus, were isolated from aerosol samples taken in laboratory settings, where you get people to cough into a machine. Great paper in Clinical Infectious Diseases in September 2021 using a machine known as the Gesundheit 2 apparatus. You got to love the name, where they had people with COVID cough into a machine that collected what they were, coughing out. And again, seeing that the virus was seen on small aerosols because they were able to split out the particles. Likewise, when you saw viable virus isolated from air samples in non-laboratory settings, there were quite a few papers in that. One of my favorite ones was by Lidnicki, when they took virus samples from a car, and they had an air sampler in an automobile with someone who had COVID, and it was detected throughout the automobile. And I thought that was quite an informed approach to this. And one of my favorite papers, and it hasn't gotten a lot of press, was from the Journal of Hospital Infection by Peter de Man et al. At Rotterdam's Erasmus University in the Netherlands. I'm of Dutch background, as you can tell from my name. And Erasmus University has a strong record of excellent work in the world of virology. And what they did, because sampling for viruses in the air is actually really hard, especially to get live virus. But what they did is they went into nurses' homes who had COVID, who were recovering at home in Holland, and took what was a small vacuum cleaner, portable vacuum cleaner that we have, the stick vacuums that we all use, and put a surgical mask on the nozzle and went around and started sucking air out so that the air would smash into the filter of the mask, and then they would do PCR on the mask material. And they found that the virus could be identified, at least the RNA of the virus could be identified in multiple locations throughout these individuals' homes. And the only way that happens is by airborne spread. They did the same in the hospital and in the ICU, and there was less in the ICU, but then that has better air handling than your average house by far. So that one was a really interesting paper. So when you start, I communicated with those authors and congratulated them. It was a terrific piece of work. And then, when you get outbreak investigations, of which there were many, where transmission went, greater than 2 meters, there's at least 9 case reports by that point in time. Again, one of my favorite is from Quinte et al. In German meatpacking plants, where they had 96 cases of COVID, and they showed the large distances that the virus traveled. And in that meatpacking plant, there were no air changes. There was air circulating because it was a refrigerated environment, but there was no fresh air coming in. And so, it was a perfect setup to spread the virus. The air was dry, and the virus spread very efficiently. And so, again, long distances, many, many meters. And then what I think ultimately the standard that we know from tuberculosis back in the 1960s was if you can take an infected animal and then have it connected to the location of a susceptible animal, but only through an air duct, then the only way that the infected animal can infect the susceptible animal is through an air duct that's much more than 2 meters. Really shows that it's transmitted through the air and through aerosols. That animal work was done on multiple animals, monkeys, ferrets, guinea pigs. But in March 2021, there was a good study done by Cutter et al. In March 2021, and I think that kind of just seals the deal when you see that convergence of evidence and replicated multiple times over, and since then even more so.
Maybe David can track those down at some point and put them in the nest or in the chat bubble, or we can post 1 or 2 of them later on.
Yep,
So,
I can do that.
Yeah. So it became apparent through your reading of these studies that the SARS-2 COVID-2 virus was airborne. And yet, even to this day, if we enter a public health institution or our dentist's office, most often there's a gigantic hand sanitizing station, and the receptionists are usually not masked, but there's a big deal made of, you must sanitize your hands before you approach the desk. So, why is it that you think that this is the case, and why do the experts in public health seem unwilling, even at this late date, to openly acknowledge that COVID is airborne?
I don't know, to be totally honest. I'm not a social psychologist, and it bothers me as much as it bothers you and everybody else, Lucy, when I see this. These are, certainly we were all indoctrinated in the droplet theory, and it still plays a role, and for other diseases. And hand hygiene is important because, there's other things in this world other than just COVID, so you still want to clean your hands. But why is it that there's not open acknowledgement and vigorous open acknowledgement by, political leaders, by public health leaders, constantly hammering us, in print media, social media, television, radio, whatever. It's airborne, folks. And this is why you need to be using the proper protections. And these are the things that we need to do about it for our schools and public spaces and all of that. And there's lots of theories, some of them talk about kind of groupthink, where people are afraid to go against the grain. If you don't want to be ostracized by the community of people with whom you associate, you go along to get along. And, that may be part of it. It strikes me as hard to comprehend in the professional healthcare world why that might be. And I wonder if that is kind of what I'm observing. People are there's an element of fear. People who have gone against the grain in either direction have been ostracized. And I think the climate of anger and the climate of fear has really inhibited just an open conversation. So we can talk about the merits of the science. I'm happy to discuss, all of the reasons that I think it's airborne with anybody else. And so, the infectious disease specialists have been ostracized. The infection prevention and control practitioners and professionals have been ostracized. And the medical profession and the public health have been ostracized. So people clam up. And I think we got to do something about that because it's not working. We need to have an honest conversation about COVID. What's really going on? What are we going to do about it? Behind the scenes, it's pretty obvious. I mean, Public Health Agency of Canada, WHO, the Center for Disease Control, on and on and on, are saying it's airborne. But they've done so quietly. And there's been theories that it's a legal concern, because we didn't do it sooner. Now we're culpable. Let's just do it, and the longer you wait, the worse it gets. And so I think that I'm favoring that we stop the ostracizing each other, and that we open our arms and embrace the issues that are necessary to combat COVID, because there is so much that we can do to significantly reduce the spread of this disease with simple interventions that we have available to us now.
Yeah, I wish they would listen to you more closely, Dick. If more people listened to you, then we wouldn't be in this frustrating and horrifying situation that we're in. For those of us who are aware of airborne transmission, to witness, people getting sick when it's completely preventable. So I
Yeah,
can only, that's just as a layman, I can only imagine your frustration with the situation.
yeah, that's for
Must be
sure.
hard to watch. Um,
It is frustrating.
yeah.
Yeah.
So in the COVID conscious community, we have many members who are suffering greatly from long COVID. Um, what are your thoughts about theories of the etiology of long COVID? Um, about your thoughts about viral persistence or immune dysregulation. What are the factors that you believe contribute to the symptoms of long COVID?
It's a fascinating area from the biological point of view. I'm not a cellular immunologist, so I'll do my best to sort of give you highlights. If you cellular immunologist is going to be able to give you the nitties and the gritties. The immune system is profoundly complex, and it's profoundly intelligent and capable of adapting. It screens us not only for and protects not only from pathogens but cancers, a variety of other diseases, and it's really the most elegant of systems. But it is immensely complex. It's fair to say that let's talk about what we call long COVID, and not a term I think we should keep using. I prefer if we use post-COVID conditions or post-COVID complications. I think post-COVID conditions, PCC, is probably the better one, because there's a broad range. There isn't an organ that doesn't get affected because it got infected. Um, SARS-CoV-2 is a virus that likes to attach to the lining of every blood vessel in our body, and it binds to the ACE receptor, the ACE2 receptor, and that's everywhere in your blood vessels because it's a very important molecule that controls blood flow. And so this virus, through the spike protein, binds to that. And we now have evidence that once it's done that, it may not go away. It may not stay inside the lining of your blood vessels. We don't quite know where it goes, but it appears that it may stay inside immune cells, certain white cells in our body, for a protracted period of time. How long, you ask? Well, we don't know yet. We're only 4 years in, but there are cases of it being there for months and years, and stay tuned, more research is necessary. Now, viral persistence is not news. It happens with the herpes viruses, such as cold sore viruses, herpes simplex, the chickenpox virus that then comes back to bite you when you're in your 50s, 60s, and 70s or 80s as shingles or varicella zoster, the Epstein-Barr virus, which we've known that it persists for a long time. We've been chasing it around, seeing what it's doing, is now linked as a possible cause of multiple sclerosis. Another virus in that group is cytomegalovirus that remains persistent in the body. Of course, hepatitis B and hepatitis C we know about. Interestingly, we now have drugs that allow us to get rid of hepatitis B and hepatitis C with a high level of success in many cases using immunological methods. HIV, of course, is one of the most challenging of viruses. It persists, and the persistence is still being worked out. All these years later, almost 40 years later, where it is, how it does it, and what we can do about it. And if we had a drug that could make it not persist, that would be a wonderful thing. But we do have very good drugs that keep it from replicating, which has really revolutionized the care of persons living with HIV. So we don't quite know where SARS-CoV-2 hangs out, probably in white blood cells, and how long it's going to be there, we don't know. There's a bunch of things going on in our immune system that are different after COVID, and particularly in those who have prolonged symptoms. And right now that's being chalked up to something known as immune system dysregulation. There's a really amazing paper published by Sylvia Hasler in Science just this last week, and in January the 19th, out of the University of Zurich and out of New York. And they looked at persistent, what they call it, complement dysregulation, with signs of thromboinflammation in active long COVID. And what that means is that one arm of our immune system is the complement system. And it's a slew of proteins, 20 plus different proteins that all pile up together to attack an invader. And they then actually create a hole in bacteria and can kill them that way. And they interact with antibodies, and it's a very elegant system. And what they're finding is that the levels of the complement proteins are altered dramatically. We don't know what it all means yet, but it's something that we can measure, because if it's a consistent effect in patients with long COVID, those are biomarkers. We can do those tests on you and say, okay, you've got the pattern of long COVID in your complement protein. So that helps us clarify a diagnosis, and also the pathogenesis. What's really going on here? And so that paper is a very interesting paper. It's a challenging one to read. It's like 18 pages long, and there's a whole bunch of proteins moving all over the page. So if you're going to read that one, sit down with a big tank of coffee, because you're going to need it. The other thing is the cells in our immune system, particularly the T cells, are being damaged, and we don't know if it's permanent damage or it's a short-term side effect of the battle between the T cell and the virus. And you're seeing something known as T cell apoptosis. Apoptosis is a fancy name for cell death. So T cells get exhausted and they die. And we're not sure, again, what that all adds up to, but it's not normal, and it means that the immune system is certainly suffering through the effects of COVID, and we have a lot more research to do. And we know that viral persistence has been found in multiple organs, in autopsy studies and in samples of tissue that have been taken. It's been found in lungs and in heart tissue, bowel tissue, and so forth. And so we've got an awful lot more to understand what's causing long COVID or post-COVID conditions. It affects multiple organ systems. The brain shrinks, our gray matter shrinks, our hearts are more subject to arrhythmias like atrial fibrillation. Heart attacks increase substantially. Of course, the lung effects and chronic shortness of breath and lung problems and lung inflammation, increased incidence of new onset diabetes, kidney damage, liver damage, systemic inflammation, neurocognitive changes. Boy, the list is long. So my hat's off to those immunologists who study this kind of thing, and we're all going to have to support that research so that we can get a treatment, because right now we don't have a treatment. What we do know is that if you don't get COVID in the first place, you're not going to get long COVID. And we know that the more often you get COVID, the more likely you are to get long COVID.
Yeah, yeah, it's very frightening, the range of effects that that COVID can have on every system of the body, seemingly. Just to get back to the T cell apoptosis, um, isn't it true that we only have a certain number of T cells in the body, and that once the T cell dies, that it is not replaced,
Well, sir,
leaving more? Yeah.
yeah. Well, sir, I mean, you need there's T helper cells and there's T killer cells, and they do a variety of different things. I mean, the human immunodeficiency virus, what it does is it goes after T cells and it wipes them out. But once in the case of HIV, when we suppress the virus, your T cells come back, and the ratio of CD4 to CD8 cells, helper cells to killer cells, improves. So it is, immune reconstitution is possible and does happen, but we need to understand more about what's going on with with this virus. And again, it took us an awfully long time with HIV, and with HIV, we don't even yet know a lot, have the answer for its mechanism of viral persistence, being hotly pursued. And so we'll use what we've learned about other viruses and their viral persistence to give us a head start on the research on COVID.
Yeah, it's so hard because obviously more research needs to be done, but in the community we're so aware of
Mhm.
of people who are suffering so greatly right now and who are, infected in 2020 and
Mhm.
have been living with this thing for 4 years now. So
Yeah,
it's very difficult.
yeah.
I guess I want to go back to what you had said, that the best way, and to our understanding that the best way to prevent long COVID is to not contract COVID to begin with. We have, at this point, we have some tools at our disposal. And one of the tools that we have at our disposal are the rapid antigen tests. But there's been a lot of kind of anecdotal information about people who felt surely that they had symptoms of COVID, but the rapid antigen tests were not picking it up. Do you have any ideas or comments about how effective the rapid antigen tests are currently at detecting both symptomatic and asymptomatic cases?
Yeah, there was a Cochrane review in last, or I guess July 2022, but by that point in time, we had a lot of experience with the rapid test. certainly it's a great thing to be able to test yourself. And we know from these lateral flow tests that they are not as sensitive as any of them, and they're used in a variety of other areas besides infectious disease. They're not generally as sensitive as direct PCR tests. However, they're easy to use. People can do it themselves. Now you can do them on saliva, which is much easier with kids. Attacking your kids with a swab is never fun. So based on the Cochrane review that was done on the rapid antigen test, and it varies by product, but generally speaking, the sensitivity to detect disease where it's present in somebody who is symptomatic, you've got fever, chills, cough, and all of that going on, is around 73%. So it's in that range. It'll vary from test to test and condition to condition, but it's in that ballpark. Which means that it can be falsely negative then 27% of the time. Which means that if you've got symptoms and you test and you're positive, it's for real, because the specificity of the test is very, very high. So if it calls a positive result, you can bank on it, especially if you have symptoms. However, if you have symptoms and you test negative, the recommendation is to do 3 tests, meaning either every day or every other day. I think if you have symptoms, you'd like to do it every day and make sure you're following the instructions as well. We've heard about the importance of swabbing not just your nose, but also your mouth. So generally what I do and what is recommended, you swab your tonsils and your back of your throat, along the cheeks, and then go up your nose with the same swab and do it that way. And it improves the sensitivity. Although most of the virus does come out of the nose, there's enough coming out of the lower airway, meaning the mouth, that it adds some value. Now, if you don't have symptoms, you're perfectly fine, but you're doing a test to say, well, I'm going to go and visit a relative and I just want to know that I'm clear. Unfortunately, the sensitivity is down to about 55%. That's quite a bit lower. So the reliability is not fantastic. It's a bit of a coin flip. Now, if you have a positive result and you were asymptomatic, well, that's probably the true bill. And then interestingly, if you're asymptomatic, but you've had an exposure, that means you're just in a higher risk group. Something's happened, you've had an exposure, you're at an event and someone says, oh, geez, I've got COVID. That sensitivity goes to around 64%. So it's best if you have symptoms, or if you've been exposed, and then last if you have no symptoms at all. And the reason is that rapid antigen tests generally need about 1 million viral particles per milliliter of fluid, whereas PCR only needs 100,000 or less.
Yeah, Dick, let's say one tests positive and one has symptoms. What do you view as being a reasonable isolation period where you know that you're not going to infect someone else?
Yeah, that's been looked at, and it was a fascinating study which raised people's eyebrows, where they took healthy volunteers who had not had COVID, and they infected them in a laboratory setting. Now, these are people who signed consent and agreed, and it was a great thing to do from the infectious disease standpoint, because we learned a lot. It wasn't a large number of people, but what they learned is, you shed for 10 days. I mean, the 5-day rule was never based on good evidence. You shed the virus for 10 days, some 14 days. And so if you're going to test yourself and see how am I doing, when am I free and clear, you want to give it at least 10 days. Some people do go shorter. Some people will clear 5-7 days. But generally it's 10 days and sometimes longer.
That's really good to know because there is conflicting information about
Yeah,
that. And of course we know about the situation in California recently where children have been told that they're able to go to school even though they're testing positive. So
right.
that's
Well,
that's
you know, that's kind of a fatalistic point of view, right? They're just saying, well, there's so many kids in the school that are probably positive that are have asymptomatic disease. Having one more kid with symptoms just doesn't matter. I'm not sure I agree with that. You know, the very
yeah.
idea, and there's a lot better approach to this than just being permissive and letting this carry on, right? There's other things to do.
Oh yeah, and you've been clear about your recommendations right from the beginning.
Yeah.
Um, So the another tool that we have in our toolbox, of course, is vaccination. Um, and we know that the uptake, especially well in Ontario here, and also in the U.S., the uptake of the XBB, the newest iteration of the vaccine, has not been very good. Um, there have been some members of the community who have said uh, who have wondered whether, given that the vaccines, the most recent vaccines, are formulated for the XBB variant, and the dominant variant is becoming the JN1 variant, is receiving the updated XBB vaccine still important? And if so, why?
Yes, and remember that the coronavirus is an RNA virus. Its genetic material is different from yours and mine. We run off DNA. That's our genetic code. And DNA replication, as we make more cells in our body, is quite accurate. And there's a editing enzyme that checks for any errors, and the DNA replication is not perfect, but it's very precise when you consider how much DNA is being copied every day in your body. Copying RNA, if you're an RNA virus, is sloppy. The RNA polymerase enzyme, as it's known, it doesn't care if it makes a mistake. That means that RNA viruses like influenza and COVID um, mutate, and we've known about uh, the mutations in influenza, and that virus, its RNA is segmented, so it's like a deck of cards, and they get shuffled between animals, and you get recombinations. COVID mutates at a rate 2.5 times faster than influenza. So that explains all the variants that we've seen um, prior to Omicron, and then Omicron itself, which was massively mutated, and then all the Omicron variants. And so we're going to see more. JN1 is flavor of the week, flavor of the month, flavor of the wave. And right now, 100,000, 150,000 cases a day in Ontario, 300,000 cases a day in Canada. Early data uh, from the State Serum Institute in Copenhagen, um, published just in Lancet in the new year, January the 5th. They looked at the XBB 1.5 vaccine that we're using now, which is the new vaccine product, demonstrated that vaccinated subjects, now they had about 442,000 subjects, have a protection factor around 76.1%. So that's pretty good. I mean, we'd all love it to be 99%, like it was in the original Wuhan. That didn't last, but this is good. This is reassuring. And it had a 76%. Now that's a reduction in hospitalization. That's what they were able to measure so far. But that's comparable to what we're seeing with prior vaccines. So we're in the ballpark compared to the control group of about 800 and something thousand. Likewise, there was a paper just in December, just before Christmas, in bioRxiv, and they looked at the emerging Omicron subvariants, and we're able to measure antibodies. And JN1 there were good antibodies produced against JN1 as well. So it's looking like we're on the, we've got it pretty good, and that the XBB 1.5 vaccine is doing what we needed to do. Obviously, the clinical studies to say, what was the exact protective efficacy still have to be done. Problem with doing that, one, is it takes a little while, and two, not a lot of people, the uptake of that vaccine has been poor because the messaging has been so garbled. Nobody knows what to do, right? When I'm walking down the street and I get asked by my neighbors who are walking their dogs with me, I'm telling them, get vaccinated, get vaccinated, get vaccinated, get the XBB 1.5. But we're less than 15% or something.
Yeah, around 15%. Do you have any comments as to, I know the Ontario government recommends 6 months between vaccines, but I'm not sure upon what that is based. Do you have anything that you want to say about frequency of vaccination or the issue of imprinting?
Yeah, I mean, I think, the frequency, the recommendation is to go every 6 months, and every 3 months in people who are very immune compromised. And that's based on what we see from measuring antibody levels. Now, antibody levels don't tell you the whole story. And they're also based on what we're seeing clinically in terms of the protection levels. And really, the vaccine does 4 things that we know of so far. One, it protects you from getting the disease. We know that, the original vaccine was 95% protective. That didn't last because the virus mutated, and then we had alpha and delta and so forth. And with Omicron, you're down, the protection early on after you've had a dose is in the 70-ish percent range at best, and maybe in, closer to the 50% range. And it wanes, after about 6 months, it drops down significantly. Still, that protection, though modest, is still at a public health level and at an individual level, still significant, still meaningful, still important. So it provides protection against infection, but it does wane. It also provides protection against needing to go to hospital, severe disease. That's not fun to end up in a hospital and be pretty scary. So that protection is higher. It's in the 70% range thereabouts, and it does wane again. By about 6 months, it's waned down significantly. Similarly for mortality, you're in the same range, around 70% range, and it does wane with time. It wanes less than protection against getting the infection, but by the time the 6 months have come up, your protection factor, both measuring antibodies by looking at what's happening to people, it's time. And so that is the basis for the 6 month, quote, booster or follow-up dose. Now, what that next booster might look like, whether it's going to be XBB 1.5, I expect it is, but will be part of the research that has to go on to say, okay, what do we need to do now? Just like we do with flu, except it happens more often, right, with COVID, because it mutates, as I said, 2.5 times faster.
Yeah, so up until now, or at the beginning of when effective vaccines were developed, after the first vaccines, there was the vax and relax kind of philosophy that if you had gotten your vaccinations, that masking was not important.
Right.
But I think everyone in this space knows about the importance of masking. How do you find masking compliance is in your area? And also, there are many people who the argument is often made, and it was made to me by a former nurse that, oh, masks aren't really effective unless it's completely fit tested,
Mhm.
professionally fit tested. So do you have
Right.
any comments about that?
Yeah, I mean, when I worked in the hospital sector, which I'm retired from now, we all got fit tested, and it was there was a quantitative fit testing. It took about an hour, and that gives you a level of reassurance that the mask is providing the 95% protection level that you're looking for. Fit testing everybody in the community is a little hard to do. You if you search around, you can find companies that will do fit testing for you, but you're going to be out of pocket not an insignificant amount of money, $50 to $100 or more. But if you want to do it, go ahead. Also, you have to be fit tested specifically to the mask that you're going to use. So if you change masks, you have to be fit tested all over again. So the protection is probably, with the fit tested N95 respirator, you're going to enjoy 95% protection if it's fit tested, if it's tight and you don't have facial hair and all that stuff. You're going to get very high level of protection, maybe even higher. If you're not fit tested, it's going to be a measure lower, but that's why we do it in layers, right? That's why when it's minus 20 outside, you wear layers of clothing. You don't go outside in your bathing suit, not unless you like being frozen. We wear layers of clothes, and we wear one pair of socks. And if it's really cold and you're going to be hiking, you're going to put on a second pair of socks. You're going to put on layers of clothing to protect yourself. Layers of protection is how you protect yourself against COVID. So you get vaccinated, you wear an N95 respirator. Maybe it's not fit tested, but you've also been vaccinated, and you're looking out where you are. Going into a crowded restaurant, you go, no, I'm not doing that. I'll pack a sandwich and eat outside. You're going to be smart about what you're doing. If you can, you increase air filtration. You buy HEPA filter air cleaning units for your home, and for, if you can, for the place where you work. And all of those interventions are part of adding those layers, and it's called Reason's Swiss cheese model, which is basically all the holes in the Swiss cheese have to line up in order for a negative event to pass through, in this case a virus. But if you put enough layers of Swiss cheese on top, the holes don't match up anymore, and you've got several of the layers are protecting you where other of the layers may not have protected you as well. So it's layering on protection is the fundamental principle here.
Thanks. What you had talked about in an article that I read, Stats Canada recently issued a report that talked about a decline in life expectancy for Canadians. Um, uh, and you viewed that as very significant. Um, what do you attribute that to, and by what mechanism was that calculated?
Yeah, we've been calculating life expectancy for decades, and if you follow the graph from, the early 1900s, when, if you made it to 50, you were doing well, and, we were, and then it's been done across the world. So we know people in Japan tend to live longer than people in North America, for example. And we always wonder why. What is it that they're doing right that we're not doing, and so forth. And because of that, and you can go to the Stats Canada, which is a wonderful treasure trove of information, by the way. Um, our life expectancy average at birth, and it's measured from, if you were born today, how long would you be expected to live, has fallen for the last 3 straight years. That has never happened. That is really quite extraordinary. From 82.3 years in 2019 pre-pandemic to 81.3 years in 2022. So over those 3 years. So that's a significant drop. And to get that drop in life expectancy, is not a small, even though you say, okay, 82.3, 81.3, okay, dropped a year, big deal. Well, that from a statistical point of view across the whole population is a very big drop. And it's dropped consistently. And it's not just in Canada, by the way. Same in the US. It's a very difficult statistic to push down. Something big has to happen. Well, gee, what happened after 2019? COVID. What I find a bit frustrating is we're hearing crickets from the government talking about this. But this is a very significant finding. And as well, Stats Canada has reported that COVID is now, up until now, been the fourth leading cause of death. So there was cancer, heart disease, various sundry accidents and adverse events, and then COVID. Well, COVID's moved up to position number 3 in 2022. Again, that's telling us what's killing us.
Yeah, and we have to think that that's an underreport because, as we know, COVID can disguise itself in so many ways. So you can have a COVID infection and then a heart attack that kills the person, and the heart attack is what is attributed to the cause of death. But how do you track the fact that it was the COVID infection that caused the fatal heart attack?
Exactly. Yeah. And so we know that there's a significant underreporting going on around the world.
And even with that, the position has moved up to number 3 as the cause of death. So,
Yeah.
if we move that up as one position, are we thinking that it's the number 2 cause of death? And, it's just not being acknowledged. The seriousness, is just not being acknowledged. And it's hard to wrap one's head around that, isn't it?
Yeah, when you let that sink in, you kind of go, wow, and when you consider long COVID, post-COVID conditions, the Canada's chief science officer called it a mass disabling event. I mean, it's that proverbial bottom part of the iceberg that I think that is the biggest issue. I think with COVID now.
So, on that note, are there any areas of research on SARS-CoV-2 now that are going on that seem particularly promising in either addressing long COVID or COVID-related symptoms?
Well, yeah, I think we know that not getting COVID at all prevents you from getting long COVID, and we know that people who've been vaccinated with the vaccines we have so far are much less likely to get COVID, long COVID, and its dose response curve. If you've had one dose of vaccine, you're 20% less. If you've had 2 doses of vaccine, you're about 50% less. And if you had 3 doses, there's a study that talks about from Sweden of a 70% reduction in long COVID. So you kind of go, wow, that makes a difference. That's in people, that got vaccinated and yet still had COVID. So, this vaccine sounds pretty important. So to me, the things that I'm following are the new potentially inhaled COVID vaccines. There's about 7 next generation COVID vaccines authorized in different countries, and that I think is very important. There's a number of mucosal vaccines which are going to be inhaled. You're either going to shoot them up your nose, inhale them through the mouth, or maybe both. And they're coming from a variety of locations. And I think this is going to be where you're really going to want to see what's going on. And there's 27 inhaled vaccines in clinical trials right now, one of which is from Canada, out of Dalhousie, Ottawa, and McMaster. So, go Canada, go. The other area of research is the self-amplifying mRNA. This is the mRNA vaccine, but that piece of mRNA isn't a one-shot deal. It copies itself. And that's looking very interesting because it would give longer duration immunity. And I think this is going to be a very, very interesting area of research.
So what you're viewing as more promising sounds like it's in the prevention kind of uh, phase, not as much, you're not as much looking at the therapeutics aspect.
Oh, yes, antivirals are rapidly expanding as well. And, the application of antivirals like we did for other viral diseases, for COVID, particularly those with viral persistence and long COVID will be very, very important. And, treatment paradigms for treating long COVID are urgently, urgently needed for the people who suffer so terribly with this. And, we need to invest serious money in this. I mean, I worry about, are we going to have enough people to do the jobs that we need done in our society? Are we going to have nurses, teachers, people to clean the roads, people to, work in the banks, people to, run computer systems? It's very, very concerning. And also the neurocognitive effects. I mean, what about airline pilots that have had some neurocognitive effects from COVID they've had, working in that doesn't give me a lot of reassurance. So I think, we need to study this in a lot of detail and put some money behind it because the order of magnitude and the size of this problem is right up there with cancer and heart disease. And of course, the funding is just starting and it's a trickle and it needs to be a flood.
Yeah, the neurocognitive effects, even on our health practitioners, our
Mm.
doctors, it's of great concern. You know, on the screen, on my screen right next to you is the avatar of Daniel Duggar, and he's always um, talking about this. So I honor you, Daniel, and it's very appropriate that you're in that space on my screen. Um, so yeah, you talked about funding, and I'm wondering whether you watched the U.S. Senate committee meeting on hearing on long COVID. What were your thoughts about that?
Yeah, I haven't watched a lot. I watched, pieces of it that come out here and there, and I watched with great interest the testimony from last week from Dr. Zayed Al-Ali from University of Washington, St. Louis. He was magnificent, and he just nailed it. And he talked about, long COVID and the implications and how we need this research. And there's no COVID, there's no long COVID without COVID. In other words, if you don't get COVID in the first place, you won't get long COVID. And if you don't get COVID over and over again, you reduce your risk of getting long COVID obviously significantly. I just thought it was the most beautiful thing I'd seen in a long time, and I was cheering him on. So, I believe that in Canada, we need a national inquiry, a royal inquiry into COVID, because we've not done that. The UK is in the throes of doing it, and the Senate is looking at select aspects in the US kind of in a piecemeal fashion. But Australia likewise has had a royal commission, and we need one in Canada. Because
How could we advocate for that, Dick, as
well,
Canadian citizens?
yeah, I think contacting your member of parliament repeatedly and whether they're in government or not, letting them know and if you get the opportunity to speak to local media, raise it. Singularly, the most important thing that I think we need to do. Now, if you want to forecast, in the Canadian political landscape, whether our current government would go for that, not likely. They're looking at an election in the not too distant future, and royal commissions don't necessarily turn out to be very complimentary against the sitting government. So, it may not be seen as a welcome election strategy by the Liberal government, but my goodness, the Long-Term Care Commission in Ontario was harrowing about what happened in our long-term care organizations, long-term care homes in Ontario in 2020. We need to have this open conversation as a nation, and we need to do better.
Yeah, and we talk about that as if it was in the past, but it's still going on. These
Yeah,
outbreaks going on in
yeah,
long-term care homes. It's horrifying to watch, and not too much information is coming out about it. I mean, I see Jeffrey Johnston in the space, and he's one of the few um, journalists who are reporting on these kinds of issues, but he's in the minority. I guess a
yeah,
few more articles have trickled out more recently, but it's very discouraging and hard to understand given the threat that we're facing, a mass disabling event. Why people don't seem to be alarmed. It just
yeah.
flummoxed me.
Yeah, the word that's been used and is kicked around is we're pretending that COVID is gone. We're pretending. And, I have little grandchildren. I love watching them pretend. They pretend to do this and they pretend to do that. And it's all make believe, and it's great for them, but not for this. We can't pretend that COVID's gone and that it's all going to go away. It's not. The virus doesn't pretend. It's very real. And we have the capabilities, excuse me, to eliminate, to get to deal with this and to really reduce the harms. We just need to do it.
You're talking about your grandkids, brings up the issue of COVID in the schools. Um, to make it personal, I guess, how do you protect your grandchildren from acquiring COVID infections?
Yeah, it's difficult. I mean, our kids wearing masks in school is going to be difficult. I mean, it's what we have, and the air cleaners that have been put into schools, I don't believe are. I mean, I don't know because I haven't. Nobody, I don't know if there's ever been audited. How many of them are still functioning? Are the filters changed? Are they even plugged in? It's very, very difficult. And again, the vaccine works really well in kids. You get very high level of protection. And that was a paper just published in the Annals of Internal Medicine very recently in children and adolescents. You get high level of protection. So you know what? Maybe we should be doing, bringing the vaccine into the schools. I remember when I was a little kid in schools, we all lined up in schools at the nurse's office to get our various vaccines, my polio shots and whatever. And because of my last name, I always remember I was at the end of the line. So I had to wait for everybody else to get theirs before I got my dose. But you know what? At least it assured that I got it, you know. And I think this is something we need to think about. But we got so much vaccine hesitancy and negativity and disinformation and just poor information in general that very difficult to imagine that the school system is going to suddenly get enthusiastic about doing that. I think they should, but and there's other technologies, obviously air handling, UV lights, and so forth would all be very, very helpful.
Yeah, that's why it's so important, and we're so grateful to have you come into these spaces on Twitter to keep us informed, and also, honestly, to reassure us that we're not crazy. Because, those of us who are COVID conscious walk around in our N95s, and we're the only ones. And sometimes it's our healthcare practitioners who are telling us no, they can give you a mental health kind of diagnosis. No, you have COVID anxiety, they call it. So it,
Yeah.
it's it's very
No,
difficult.
I have the same issue. People, I have to go and visit a dentist or sometimes my doctor at the same, just like anybody else. And I have those same issues, and I know what that's like. And I don't take no for an answer. I have walked out and saying I'm just not doing this, and I'll go somewhere else. That's sometimes hard to do, particularly for services that are hard to come by, like, family doctor. Then having an open conversation, bring a mask with you, and say, here, it's in the package. Why don't you just wear it for me? Humor me, and I try different tactics like that. It's not easy though, and so far, my dentist, my family doctor's been wonderful, and their clinic is still using full precautions, and I'm so grateful for that. But when you go into the hospital, sometimes right now they're wearing masks, but a lot of them they're not. And I ask people politely, would you please put on a mask? And generally, it's not a problem.
Uh, okay, well, I don't want to take up too much of your time, and maybe we'll have time for one question if you're
Sure.
agreeable to that. But I like to ask the crystal ball question. What do you envision the situation could look like in 1 year from now, or in 3 years from now? Given the current climate,
Yep.
what do you see down the road?
Well, I'm an optimist. I have to be, otherwise I don't see, what's the point of being anything other than that. I expect we're going to have a very successful year, and by late 2024, perhaps early 2025, a next generation vaccine will be available. I'm hoping that I envision it'll be an inhaled vaccine that will have, substantial protection against actual infection. And I think that will be a game changer for us. That's what I really hope and I expect to see. That I'd like to see more money um, than what's been put into it, but and I would love to see Canada, play a much bigger role. So I'd love to see more money into that. But I believe it's very likely that is where we're going to end up. We must advocate, in my view, for a royal commission on COVID in Canada. That somehow has to be structured so that it looks at the response across all levels of government, not just one or the other. And I think rebuilding trust in public health is going to take a really long time, if it ever comes back. That I'm not optimistic about. It hurts me and it pains me to say so. I've worked in that space, with those folks for a long time. I think trust in government, which was never great, is not going to get any better. And we really need to seek out leaders in your community, in your local political riding associations. Get involved. Join your local riding association or the political party of your choice. Get involved. That's where the action is. And when elections come, you can help select candidates that meet the need, that are the right people, and will be able to do good when they get in. Because when that happens, when there's an election, we want to have people who get elected who understand this for what it is and how significant, an event of the century COVID really has been, and what suffering it has caused and continues to cause, but how available good solutions are.
Thanks, Dirk. Do you have a couple of minutes to take maybe one or two questions?
Oh, sure, my pleasure. Happy to.
Oh, great. David, so people who had questions were to DM them to David, the co-host. David, do you have any questions? Can you call anybody up?
Yeah, RP is the first person who posted a question. So maybe bring him up.
Okay, I'll do that. Invite to speak. RP? RP, if you're still there, I've sent you an invite to speak and you'll have to click on that. RP might have stepped away.
Hi, good
Okay,
evening.
David.
Hi, good
Oh,
evening.
you are there. Hi, RP.
Hi, good
Welcome
evening.
to the space.
Thank you. Thank you for hosting the space, and thank you for coming here, Dr. Zoutman. Um, one of the questions, well, I have two. First one was the first coronavirus pandemic that we were aware of. That was uh, nearly as not as extensive as this, but was probably the Russian flu. That was OC43, I believe, and that I think lasted about 3 or 4 decades or more. I mean, before it became the common cold, it was a pandemic, I believe, for about 4 years. That was a different subgenus, but SARS-CoV-2 is a different subgenus of viruses, the sarbecovirus. Do you see any way that that pandemic could predict or help us manage this one?
Yeah, the coronaviruses we have stealthily and much to our peril ignored. In many infectious disease books, they warrant a half a page, and they cause a common cold, and that's about that. You're right, and the veterinarians will tell us that coronaviruses cause a lot of disease in the animal kingdom as well, and quite significant. And they don't have a problem with the airborne spread. They see it spread in animal husbandry and in barns very readily. So I think understanding how coronaviruses have behaved in the past is critically important to understand how they'll behave in the future. And so with the and it's interesting that it started out, as you say, in Russia as a more virulent strain. It seems to have become less virulent. What is that all about? And what was the mechanism of that? And what can we learn? Maybe we need to pull some of those original strains, out of maybe permafrost somewhere and study the differences over time, because it may give us a way to map which way this is going to go, and what is it that is favoring. I mean, we've had three coronavirus events, in the last 20 something years, right? SARS-1, MERS, and now COVID. That's pretty accelerated, so we better take a long look at the evolutionary biology of this virus, because what's the next one, And so, no, you make a very valid point.
Yeah, and I think that was something that Dr. Ali spoke really eloquently about at the committee hearings. I found him very impressive as well.
Mm-hmm.
So, RP, you said you had a follow-up question?
I'll take a follow-up question if other people don't have a question.
David it up. Are there other people with questions?
There was Ulfbear and then John.
I think I also saw Daniel has requested, but Ulfbear, let me see. Ulfbear, do you want to send a request? And I think also Jeffrey Johnston has a request. Ulfbear, if you don't request, then I have to look through all the avatars to find you, and I can't do that. So let's go to the next person. David, who did you say?
So it was Ulfbear and then John.
Okay.
They both had good questions.
Okay. David, are you able to find Ulfbear to invite him up? No. Okay. Let's let John go ahead. Hi, John. How are you today?
Yeah, hi Lucy, hi David. Thanks for having me in the space. Good evening, Dr. Zoutman.
Hi.
Yeah, I was able to catch the beginning because I had to take a phone call, but the beginning you were talking about your experience in SARS-1, and I just wanted to trade some notes with you in perspective because I'm from Toronto, and I was leaving college, or I was in college during SARS one. So it definitely had a huge impact on life in the city and careers, and also because I have several conditions that I was born with, it was something additional to, learn from at the time.
Mhm.
And that, that basically we could say we as a city, the cities that were affected with SARS did those sacrifices, and the world didn't have to deal with SARS 1 again. So we lived those last 20 years like with the problems we had, but not this, right? And so I just wanted to compare some notes because you said that SARS is much more fatal, and I kind of hear this sometimes, and I just want to question it because there's case fatality rate, which is a math equation based on the cases where how many infections you have and then how many people died. But there's another viewpoint that if something's very infectious, and regardless of so if there is fatality with it, the sheer infectiousness of it means that whatever that percentage, although we may consider it small, will quantitatively end up being much bigger, which is still fatal, right? So if we look at the number of deaths worldwide, because nations, they report their own cases, but I like to look at it worldwide. So it's almost 7 million. And SARS, the deaths were in 774 officially, right? So it's almost 800. But we don't have to do a math equation to divide 7 million by 700, to realize that SARS-CoV-2, is much, 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 much more fatal. And I hear this about SARS-1, even though our experience of SARS-1 was that it was very fatal, because back then we didn't have the internet, we weren't interconnected, 8,000 cases worldwide. We didn't know 8,000 people in our lives. So 700 people dying was a huge amount. But now that we're here, I feel like just the level of how much more fatal it has been needs to be stated. I guess that's my perspective, and I just want to hear from you on that idea, that because me as a person, I'm not really that scared or concerned when I hear of a virus that has a high case fatality rate, because though I'm in a vulnerable, I guess, population, I look at the normal people I want to use the term normal in quotations, but like able-bodied people out there feel the threat, and they will do the things necessary. Ventilate the air, use negative pressure rooms, respirators, reusable respirators that look tough, and they will use those, and they will shut down the cases for their own self-preservation. But when the case fatality rate is so small, that burden gets passed on to those who are already on the edge, vulnerable or disabled or financial means, and so that's just something I want to put forth. And thank you for letting me share notes with you. So it's because it's really special to hear from someone who was in that position during SARS-1. So thanks.
Yeah, no, John, you make a very valid point. I agree with you completely. The damage done by SARS-CoV-2 has been enormously larger worldwide. The case fatality rate talks about the risk of one case dying on average, right? So yeah, on that calculation, SARS-1 had a higher case fatality rate, but the overall impact of COVID has been, there's no comparison. 7 million deaths, which is probably a serious underestimate, and people talk about doubling it or more worldwide. And then untold misery. And when I read about the number of children that have been orphaned, as an example, it just it makes you want to cry. And then there's the implications of long COVID, which is a big multiplier because, as I say, it's the bottom part of the iceberg that's much bigger than the tip of the iceberg in so many ways. So no, you're absolutely right. We have to take into account the total impact that a disease has, even if the individual case fatality rate is seemingly low. Remember as well that the case fatality rate with these coronaviruses, but certainly with COVID, is age dependent. So although the mortality in a healthy 20-year-old who has no other health challenges, will be a fraction of a percent, a very small number. The mortality in someone who is 75 with chronic obstructive lung disease, diabetes, and other things, is substantial. And in the elderly, over 80, is in the 15% range, taking on average. Even now with the vaccine. So I think you have to take each individual case and look at your individual risks, and everybody's unique and have their own health challenges and other risk factors. So no, you make a very, very valid point, and I agree with you.
Thank you, John. Thank you for your question. I think we'll take a question from Jeffrey Johnston, and then Daniel Duggar, and then we'll wrap up. Go ahead, Jeffrey. I'll bring you up. Hi, Jeffrey. I don't think many introductions are needed. We all know and love Jeffrey for his work with the Whig Standard, one of the few reporters, investigative journalists who's covering SARS-CoV pandemic. Yes, Jeffrey.
Hello, Lucy.
Welcome.
Thank you very much for hosting the space, and thank you, David. Hello, Dr. Zoutman. It's good to speak with you again. I hope you're doing well.
Nice to talk to you too,
And
Jeffrey.
I also want to thank you for being one of the few experts to really step up and speak publicly about these issues. And you're a gifted communicator. So my question for you is this: Dr. Peter Hotez, who was nominated actually last year for a Nobel Prize for his work on a low cost patent-free vaccine for the developing world for COVID-19, recently wrote a book about anti-science aggression, in which he detailed the rise of this ideologically driven attack on science, and it also has the unfortunate nexus of anti-Semitism, because Dr. Hotez is Jewish, and so there's been this convergence of anti-Semitism and anti-science aggression, and we've seen that here in Canada. A number of physicians and scientists who are Jewish have also been attacked, and we have seen this unfortunately very successful anti-vaccine, anti-mask, anti-PCR campaign by these anti-science forces. So with all that in mind, my question is this: given the anti-science aggression of the 21st century, what are the three things that we need to do or need to happen in order to bring the SARS-CoV-2 pandemic to an end? Thank you.
Wow. Can I use both sides of the page as necessary to answer this question? Yeah, I mean, I think we need to have better science literacy in thinking in the school systems. And I think we need to have, our children need to understand more about how science really works. They need to have hands-on observational skills so that when they look under a rock and they see some little creepy crawly, that they respect what they see, but also know how to evaluate, a microscope, and they learn how to look at it, and they learn how to understand biology, but also chemistry and physics and the other and the other sciences, including, I put math in there, although some people would argue with me. And I think we are going to have to teach our children to be discriminating consumers of information. Because right now we live in a world where if I say something, a lie, loud enough and often enough, suddenly becomes true. And that is what I think is causing an enormous amount of damage. And science is not clean; it's messy. You rarely do a set of experiments and get a result that suddenly changes the world. It has happened, but usually it's one step at a time, and it's an investment, and it changes. And COVID's been a really good example of that, right? We thought we had the vaccine nailed back in when the first paper in the New England Journal on December 31st, 2020. Okay, we got this done. We got 95% protection. Goodbye, COVID. You're done. It didn't quite pan out because science is messy. But people aren't being discriminating users of information and are not appreciating how science really works, because I don't think they're getting enough of that in the school system. Our children need to be better consumers of and analytical in their ability to really discriminate, garbage from true information, and understand why science, is a process and it takes time. In terms of other things that we need to do, we absolutely have to elect and draw in people into public life, political life, which is not for everybody, who are conversant in science, ideally, not just science. We need people from all walks of life, but to encourage people who are open-minded and to get involved in the process. And that means all of us need to, as I said earlier, join your local political party and participate in the process of selecting candidates and having candidate meetings and deciding who's going to run in your local riding, and then going door to door, as I have done with the party that I support, and hearing what they have to say and talking to the candidates and really getting to know them. You realize there's some tremendously gifted people out there, but they need to know that they've got support as well, from their community. And so getting involved matters, because the last provincial election in Ontario, the voter turnout was the worst in a long time. And, I think that's really sad. In terms of the third thing, I think we need to have better communication. This is where you come in as a journalist, I think, to be able to tell the story. And I know you're trying very hard, and you're one person, but I have also been struck by how the media is important, and journalism is important. It's a core function of a democracy, and we need to have, I think, a different standard in our journalism, because a lot of it's become a blood sport, and we are following the examples of what we're seeing in other jurisdictions that are very negative. And we need to have not only high journalistic standards, but also be able to get the truth out, and not stand for the misinformation and the disinformation. Because if you say a lie often enough, it becomes the truth. It doesn't. It's still a lie, and it does harm. That's my attempt to answer your question, Jeffrey. Thank you. Great to work with you, by the way, and to have you, championing the cause.
Thank you, Jeffrey. Yeah, I'm conscious of the time. Daniel, you can ask a question, but I'm going to ask that you limit it to maybe something that can be answered within 5 minutes, and then I will close out the space. So let me bring you up. Good evening, Daniel. How are you tonight?
I'm great, Lucy. Yourself?
I'm well. I'm well. It's nice to hear from our friend from the South. What question do you have for Dr.
You know,
Zoutman?
it's not really a question, it's more of a comment. And he mentioned earlier about research. And, you know, you mentioned my studying the neurocognitive aspects of this. To be honest, we really don't need any more research. I mean, we've seen the same pathophysiological processes described over and over again, and it is just being regurgitated. And you know, we're not paying attention to the fact that we've got millions of individuals living with a chronic infection that is resulting in immune system dysregulation, uh, cognitive impairment, and, you know, most importantly, insult to the kidneys and liver due to ACE2 receptor distribution, which is really the unappreciated genius of this virus. And so, you know, I think we just need to say we've got enough. Non-pharmaceutical interventions are not working. Masks, people have an aversion to those, just as they do condoms. Vaccines aren't as protective as they need to be, and we need to start moving to a treatment as prevention model. You know, you're in infectious disease, and a pill-based strategy changed the whole landscape of HIV. Of course, we went in the opposite direction with PEP first, PrEP, and then TASP. But with the number of people that we have infected, you know, if we were to go in reverse order, you know, we would get somewhere, as opposed to where we're at now with tuberculosis reactivating across the United States, which, as you know, is an AIDS-defining illness and the number one cause of death in the HIV-positive population. Cryptosporidiosis is popping up in the UK. You know, it's quite evident that there's tremendous amount of immune system dysregulation. And we've not seen this really except for, you know, 40 years ago, and if we don't watch it, we're going to end up repeating history even more than we already have. So I'm hoping that we'll start moving in that direction and talking about a pill-based strategy. And you know, we're in a society shaping exercise, uh, and we were tasked with preserving the current generation and the future generation. And so far, we've miserably failed. And we're the only generation that anyone can say that about. Otherwise, we wouldn't be here. We would be dead or never even born. And so, you know, we've got to appreciate that and do something to preserve the society in which we live, where it's not plagued by senility, which is where we're going with Alzheimer's patients, those living with Parkinson's disease and myotrophic lateral sclerosis. We know that that's going to happen because people's microglial cells in their brain are all loaded up with virus.
So, Daniel, is your question for Dr. Zoutman whether he believes in a pill-based strategy or a prophylactic
Yeah, I mean, you know,
pharmaceutical strategy?
yeah, I mean, yeah. Does he agree that we've got enough that we need to start doing something to
Thank you,
yeah.
Daniel. Thank you. Let's let him answer. Yes, Dr.
Yeah, thanks.
Zoutman?
Yeah, thanks, Daniel, for your question. I mean, yeah, I think we do need better antivirals against coronaviruses, and that work is proceeding. It can't happen fast enough. I mean, I reflect on, you know, when AZT, azathioprine, came out in 1981, 82 for HIV. You know, it was heralded as you know, it was a start, right? And it didn't solve all the problems, but that whole line of investigation has made a huge difference. Hepatitis C, we can eliminate now people with chronic hepatitis C. So and hepatitis B, we can eliminate in many cases. And so you know, we do need to invest in more understanding of how this disease works, how do we inhibit it with medications, We can screen for many medications very rapidly now, and we need to bring them, to to the clinic, as it were, as quickly as possible, not only for acute disease but also for the long COVID, which of course is a scourge unto itself. Thank you for your thoughtful question.
Okay, David, it let me know that Dr. Leonardi was in the space. I can't seem to see him now. And if he
It
has a
was AJ.
question, yeah, AJ Leonardi, correct?
That's correct. I'll bring him up.
Okay, thank you.
Sorry about that.
No problem. I looked down in the space and I didn't see him, so I'm wondering if he just had to leave.
Yeah, I just saw him, but he may have just dropped out.
That's too bad. Okay. Well, Dr. Zoutman, I'm going to wrap things up and by thanking you really so much for the generosity of your time, your commitment to keeping us informed and safe. Oh, here's AJ Leonardi. Hi, Dr. Leonardi. I guess you had a question for Dr. Zoutman. Good to see you. You're muted, AJ. Dr. Leonardi, did you have a question for Dr. Zoutman? Maybe, David, maybe Dr. Leonardi is having technical problems.
Yeah, I think
That's what
so.
it, yeah, can you drop him? Oh, here's his request. I brought him up. There we go.
I'm sorry about that.
No problem.
It's a simple question, but the answer is probably not simple. So, and I'm passing the buck to you, Dr. Zoutman, because I was asked this question by Professor Singh, a virologist from India that often comes and poses questions to me. And the question he asked is pretty much this: what would you expect the upper and the lower bounds of the natural history of chronic SARS-CoV-2 infection in the many people that have a chronic infection but without long COVID from the latest data? Like, there was a paper where they took biopsies and they got 40% of people in these biopsies and they did not have symptoms. My concern was from the very broad stimulation of T cells that occurs by whatever mechanism, be it a super antigen, be it bystander activation, be it complement, that if it does this acutely, it could possibly do this broad activation in a chronic fashion. So with that in mind, I'm passing this question from Professor Singh to you.
That's a difficult one, to be honest. I mean, I don't think, in all honesty, we don't know. I think it's, it could be very high if the virus is a binding to ACE receptors. Generally, it could be very high, maybe even 100%, God forbid. But the other part of the question is for how long? What's the area under the curve? How long is this going to remain? Inside wherever it goes, and we know that with other viruses it's common, right? And it's not an uncommon thing. When you get a herpes infection, most cases go on to become persistent and to have viral persistence. So that's bad news from the point of view, and I think it should stimulate us to want to do something pretty quickly, because the implications are very significant. Now, How long? That's the part we don't know, and let's hope that works in our favor.
Thank you. Thanks. Thanks, Dr. Leonardi. Thanks, Dr. Zoutman. Again, thank you for your time and your commitment to keeping us informed and safe, and for your decades-long service to healthcare, particularly here in Ontario, which is also where I am located. Thanks to all of you who came to listen. For those who were unable to attend or who came in partway through, or who just want to re-listen, a copy of the recorded space will be pinned to the top of my profile. Please feel free to retweet and or to invite friends and family to listen. David It Up, my technical wizard, is going to make a recording available on YouTube, and I will also post that link when it's available. So that will end the space for this afternoon. I'll leave the space open for a few minutes for those of you who just want to look around the room and follow any other participants. Otherwise, thanks again for coming. Take
Thank you,
care.
Lucy, for asking me. Appreciate it. Take care, everyone. Stay safe.
Thank you. Stay safe, everyone.